Hello and welcome to today's PIR live event brought to you by Partners in Research Canada. My name is Stacey Joyce and I will be your host. Today's guest is Dr. Doug Jones. He is a professor in both the Department of Physiology and Pharmacology and the Department of Medicine. And he is also the Vice Dean at the Schulich School of Medicine and Dentistry, all at Western University in London, Ontario. Thank you so much for joining us. I will let you take it away.
Oh, my pleasure. Very good to be able to talk to a number of people about some of my passions. I'm going to give a little bit of a presentation of some of the things that I do, in particular what's related to what I see as being advantageous for a lot of students who are looking at the areas of medicine as a potential career. So I'm going to start by sharing the slideshow, and I want to just make sure that everything broadcasts well enough and that everybody's on. So I've entitled this Tools, Targets, and Techniques for Arrhythmia Identification and Treatment. And the reason I'm doing that is because of the basic component of the heart being an electrical organ. The only way it pumps is through electricity, and that electricity follows a particular pattern going over the heart, starting from the top to pump the blood into the bottom chambers, then having a delay, and then the bottom chambers pumping out to keep the blood flowing through the body. And for you and I, that means about 2 billion heartbeats in a lifetime. So that's an extremely important component. And what we're dealing with is the fact that if you don't have that activity, there are a lot of problems that are there. And we're trying to identify what those problems are and what we can do about it. So I'm going to talk a little bit about the atrial arrhythmia. That's the top two chambers of the heart. And I'm doing so because they are the most common problem that's seen in general practice. And the key element for me is to try to find where the problem starts. And we can do that by mapping electrically, by cooling different areas called ice mapping. And then with that, we can find the particular target. And yes, that's extremely important to find the right target to ensure that you've got the right thing you're looking for. We can also model some of these using animal models, and one of the ones that we find the most useful now is a mouse model. And this is a picture with a small electrode. This is a 1 centimeter scale, and you can see the number of electrodes that are on this little catheter that we put down inside the mouse heart. And here's a CT scan inside the mouse heart, and you can see those electrodes inside the heart that allow us to look at what's happening in the atrium as it gets conducted through the His bundle and down into the bottom of the heart, the ventricle. By using electrical stimulation, we can try to induce arrhythmias that we see in people. So this is the standard limb leads and then some electrograms from inside the heart that show that activity going through the top of the heart, the atrium, then through the bottom part of the heart, the ventricle, in a regular pattern. And then by giving a little burst of electricity, we can turn on an arrhythmia that is not following the normal pattern within the heart and look at where that's coming from and what the mechanisms are and how we can treat that. So for a long time, atrial arrhythmias were just thought to be not treatable, not identifiable, not treatable. But now we know that there are ways of treating those, either electrically, we can use drugs, or we can do it surgically. I won't have time to go into all those today. In particular, I'm not going to talk at all about drugs. Many drugs also have side effects, which we'd like to avoid. So what can we do when drugs fail? So we really look at the possibility for detecting where it is and then destroying that starting part. So we can do that either by heating it up, or freezing it, or surgically removing it. So here's an example of what I was talking about earlier. This is preparing for one of those surgeries. And you'll notice that no one in this picture is looking down where the tools are. They're all looking at a screen because this is being done with virtual reality. And for virtual reality, we need a programmer. We need an engineer to design components. We need the surgeon to test the piece, and we need a model from which to work. And with that, using an image of the individual patient, we can maneuver those tools in and out of a beating heart You can see the blue and the red tools here moving in and out to find different regions in that heart in which we want to either ablate a region or identify where things are coming from with a virtual reality capability of doing that. So here's an example of doing exactly that. And you can see I'm here on the right, on the left rather, and I have two little television screens in front of me that allow me to see what I'm doing down here at the table in 3 dimensions inside a closed chest, inside a closed heart. And I'm working with my colleague here, Surgeon Gerard Guiraudon, as we're developing some of these tools and techniques. And one of the key elements in this is that if you have a problem that occurs when you're born in the fact that these vessels in the top are not in the right positions, one of the key elements that's done for that is to try to see where those are occurring and to correct it. To do so, we've designed a tool that allows us to introduce a number of different elements into the heart chamber, even though the heart is still pumping. So this allows for the manipulation and the changing of tools in that chamber. But the difficulty we had was there was no device that could hold the introducer stably. So we designed this little tool using some of the standard holders, and I want to direct your attention to the shape of the gripper at the end here and the shape of the spreader, because you'll see those in a moment. So for those of you who think that all these marvelous devices are designed only in highly sophisticated laboratories, I want to show you the initial first prototype that I made for the device we're going to use for the pieces there. And this is made from a piece of PVC piping, the terminal part that came from the Home Depot, and then adapted that with a number of input ports that we use. So this is the first prototype that we then developed and then perfected, which we used then for the patient, that allowed us to introduce elements into the heart using these ports. So the patient I want to talk about is an individual who had a problem in the aorta and the pulmonary artery that didn't allow blood flow properly. So the only way this could be corrected was by putting in a piece of Gore-Tex. That's the type of material you have in a ski jacket that connected up parts of the components that would then deal with returning blood to the correct part of the heart. But because this is now separated from the heart, we couldn't get into the atrial tissue. That RA is the right atrial tissue, because it was closed off. We no longer had our normal access points to get in. So the problem here was we could identify some issues from there, but we couldn't do anything with the tissue. So we took that port that I showed you before and put it onto the left side of the heart, which allowed us to introduce some of these electrodes and ablation catheters across the left and into the right atrium to correct some of those arrhythmias that were going on. So some of these electrodes are like the ones I showed you in the mouse that allowed us to record what was going on. So this is the connection for the lower part, which is being sewn onto the heart. This is the connection for the upper part, in which we can put the various tools. And yes, there's a patient here. This is one that was actually done by us in Paris over a year ago. And the patient is underneath here, and we have a number of nurses, cardiologists, electrophysiologists, engineers, and people doing the anesthesia, watching some of the tools and techniques that were going on. So it gives you an idea that this is not done by an individual. This is a team that's necessary to carry out that work. And this, you can see, is that adapter holding on to the patient. And this is an X-ray shot. And you can see that little 3-forked adapter that's actually holding on to our introducer, that's introducing these wires into the heart, that has allowed us to electrically map where that rhythm is starting. And most of you look at from the outside of the heart, don't realize this is what we look at on the inside. So this is mapping the electrical activity in the inside of the heart, trying to find out where it's starting. And these lighter and red colors is the starting point of where that arrhythmia is beginning, and it's right in here that we had to get to. So these are some of the ports coming into that atrium, and that's where we had to get to do the ablation. that part, and down here. And so this was a successful surgery, but it took almost 12 hours to complete the entire surgery on this individual patient. But I think that it is a very good example of making use of that combination of technology, identifying where the critical targets are, recognizing that we need a team to be able to do that, and then having a suitable outcome for a particular patient. So this is some of the team that have worked on some of these works, and I just want to acknowledge the fact that I am only one of a number of people doing this work, but it is a recognition that there are a number of opportunities in the medical field beyond being the surgeon or beyond being the cardiologist and beyond being the physiologist as I am. So I want to stop there and give you an opportunity then to ask some questions, anything you have in mind about the components of what's here. I have been on the medical admissions committee as well. I, of course, deal with both the undergraduate, the graduate, the postdoctoral, and the fellows programs in the areas in medicine and dentistry here at the Schulich School, Western Ontario. So thank you for listening to my short talk, and now it's up to you.
Excellent. Well, thank you so much. That was very interesting. I'm just wondering, you had an acknowledgement slide there at the end with a long list of people who have contributed. What are perhaps some highlights of the positions that those individuals have or the experience they bring to the table?
So as I mentioned, it's quite a combination. So some of those are students who are doing projects. For example, that mouse study that I showed you is one that's been carried on by a couple of students with different models. We have some technicians in that list, the ones that were helping out with both the animal and the patients. There are some nurses in there. I have colleagues who are in physiology. I have colleagues in the Department of Medicine and cardiology. I have a couple of surgeons that are in that group that I mentioned there. Some are here in London. Others are in Paris at the institute there that we did the surgery. We have a couple of anesthetists in there as well. And then I'm trying to think of who I'm missing. A couple of engineers.
Okay.
So it's quite a combination.
So what are the steps perhaps in the people involved in those projects before it comes to the surgery? There must be a lot of development that happens before we even think about testing that out on a live person.
There are indeed, and there are different phases of that. So in the engineering side, for example, there are an awful lot of things you can do on a bench. You can do it in a simulation, as I was showing in that one slide. There are a lot of programming that goes on that allows you to merge the images from what was taken in a patient to what's on the bench. In addition to that, then once we have some idea of the tools we can use, the other aspect is developing where are the targets. So that's, again, the mouse studies that we've done, some of the other animal studies that we've done, to identify where are the critical targets, what can we do about them, can they be treated electrically. Many of you probably recognize the term pacemaker, both from the using for the heart itself when it's self-exciting, but also for a device we put inside. We have pacemakers that go into people who have trouble with issues. But pacemakers can also be used to overdrive and suppress an arrhythmia, as well as to pace when there isn't a rhythm that's going on. So there's an awful lot of development going on in those areas before we would then decide the most appropriate in this patient is to go for the surgery. And then we have the surgical techniques that we're using, and some of those also relate to whether or not we're going to do an open chest where we have a lot of exposure, or are we trying to keep the chest closed and only go through little port entries, those tools that I was showing you in the video. And part of the issue there is for port entry, you only have a certain part of the heart that's accessible. So you would then design, depending on what part of the heart you're going to, where the port would be located and how you design those. So again, there's a whole series of studies that go into designing the ports, the tools that allow you to get in, and then the targets you're after. In my case, once we have that group together, we'll replicate that to the best of our ability in an animal. If it's only trying to identify individual little targets, and mechanisms, we can do that in a mouse or a rat. If it's looking at the tool which we will use in the patient, we need a larger heart because the tools we will be using are larger. So we need to model the patient's heart, and for that now we quite commonly use the pig. And the pig model is good for two reasons, one of which is it's about the size of a young person's heart. But the second reason is that some people are trying to develop the use of pig hearts in the case of someone who needs a transplant and there isn't a human heart that's available. So we may be actually looking at a patient who has a pig heart and doing some surgery on that. So it's a good reason to do both.
Excellent. Well, we have some questions coming in from our viewers now. So I am going to first ask a question from the grade 8s at CRW in Oakville, Ontario. One of the students is asking about your education, Dr. Jones. What did your educational pathway look like?
A little tortuous. I didn't have this in mind from the beginning, but if you think of where I started out, I was interested mostly in math and chemistry. So I got an honors degree first in math and chemistry and then decided that the biology part was becoming more and more interesting. So I ended up taking extra courses in the summer and switching over to the zoology side. And then from there went into the medical sciences. From the medical sciences, then I went in and did a master's degree followed by a postdoc, a graduate PhD and then a postdoc. And then from that, we were developing some of the developments here that looked like it might be interesting, and so we did some collaborative work at that time before I got into being on the science side on the faculty. So if you're thinking of it coming out of high school, to get into a medical program, most programs require a standard 4-year bachelor's degree. After that, most programs have a 4-year medical degree. Then depending on your specialty, usually there's a 1 or 2 year general, and then anywhere from a 3 to a 5 year, sometimes a little longer specialty training beyond that. So after high school, you're looking at anywhere from 10 to 15 years post-high school of additional training, depending on what specialty you're going into.
Now, you specifically call it additional training, not necessarily school. So our students in elementary and secondary school are used to going and learning all day, and there's some doing involved. But when does that shift in the training to more doing as you learn than reading and learning that way?
Well, as soon as you're in any of the lab courses, you're doing some of the doing already. So even in first year, we have that. Some in high school with some of the labs, we have that. But I think the real shift in collecting more information and being responsible for your own learning happens more in the university system, and particularly as you get to the later years in the 4-year program. Certainly in graduate work, the expectation is you're taking on a lot more of that responsibility for yourself. You are the one who's going to be expecting to be a lifelong learner going out, so you need to be using those tools and techniques as you're going through the process. So that's why I call it more training. It's training yourself to be able to be a self-starter, to be able to be motivated to find the information you need or to work on the pieces that you need to develop, and then to recognize where your limitations are so that you can put some additional focus on those areas rather than just having somebody tell you this is an answer. Having someone tell you this is an answer doesn't help very much a few days later when you're trying to remember it. But if you discovered the answer, or if you work with the answer, you retain it. It's much better learning experience. Plus the fact you can then adapt it to different situations. So you may have learned it in one situation, but you can adapt it to a different situation.
That makes a lot of sense. I think that must be true at every level of schooling, training, working, etc., no matter what field they choose. So that's great advice. A few more specific questions from Mr. Zhu's class in Toronto. They would like to know if professors work with undergrad students, or is it mostly just the teacher's assistants or TAs?
It's a combination. Certainly because of the classrooms and labs, we have TAs to help out because there are, many students, and there just isn't time for a faculty member to spend, a good amount of time with each student, whereas a TA can dedicate time there. But in the programs that I deal with, of course, there are also office hours, and students do come. And in the fourth year, in all of our major courses, we have what we call a capstone course. And the capstone course is where a student works in an individual's laboratory. There's a lot more one-on-one activity going on there. We also quite often have journal clubs in which there's interaction going on, and a lot more of that is individuals and faculty members who are participating. So it's a lot more participatory as you go from first to second to third to fourth year. And then when you get in the graduate program, of course, it's much more than that. The other part is it will depend a little bit on which lab you're working in. And in some of them, the labs are quite large, so the opportunity then is much more to interact with your fellows and your peers and those who are either a little above you or below you than it is with a faculty member. And indeed, a lot of the best learning can happen in that environment because you're bouncing ideas off each other and you're having to describe what you know, and really that really helps you understand what you know as well as what you don't know. So that's helpful.
Mm-hmm. So another quick question from Mr. Zhu's class. They'd like to know if Western University and other universities consider grade 11 marks for their undergraduate admissions.
For the early conditional, we look at grade 11 marks, but the cutoff is much higher. And the reason we feel that we can do that for a conditional offer, and they have to maintain their average, obviously, is that the probability of somebody who's been performing very well in grades 9, 10, and 11 to suddenly drop off the cliff in grade 12 is rather low. There will be one or two, but it's very infrequent that happens. So if you have a very good average in grade 11, the chances are you will continue to be so and you will be acceptable. So the early offers are based on grade 11. The second round of offers here are based on the first term of grade 12 plus the grade 11, and now we can drop the average a little bit. And then the final offers, of course, are based on the final grades coming out of grade 12.
So if a student maybe wasn't particularly motivated in grade 11 and they've gotten their act together by grade 12, will their grade 11 marks have any effect in that third round at all?
So it will also depend on how much they've changed. Obviously, if they're just scraping by in grade 12 and they were doing very poorly in grade 11, they wouldn't make it into a competitive pool such as the one that we have here. There are different requirements, though, in different universities and different levels. Western tends to be one of the higher ones in Ontario, and the medical sciences program that I'm responsible for here has a higher cutoff than the University of Western itself as well. So we are looking for very highly qualified students coming in to the program. Once they're in the program, though, if they maintain their average, there's no problem in progressing. But the entry to the Bachelor of Medical Science program here really starts after second year.
Okay.
So we have a better idea of how well the students can perform at the university level, because there are some discrepancies between the high schools, and there also is a thing that I know from my own children, this thing called maturity, and having a few more years behind you actually does make a difference.
Yes, I have experienced that myself. So we have some more questions here about how students can get themselves prepared. So we have questions about in grade 12, what can students do to prepare themselves if they would like to get into medical school as a step along their career path? And what courses in university, perhaps, because you did mention that we're not going from high school to a medical school. There is a requirement for usually a 4-year bachelor degree before going to medical school. So from grade 12 through university, what can students do to prepare themselves?
So I start the other way around. I start by asking, what are you interested in? Because if you study what you're interested in, you do better. When you do better, you're more competitive regardless of where you're going. If you didn't get into your first choice, you still have second and third choices in things you like to do. So I start with that. Given that, if you're really interested in medicine, why would you not be interested in things like biology, physiology, pathology, biochemistry? Because those form the basis, along with anatomy, of medicine. So it makes sense for those who are interested in that to be thinking about those kinds of courses. If you're not interested in that, maybe what you're more interested in is some of the other aspects, like the engineering side. So maybe the mathematics, maybe the science ends. Maybe some of those other ones in construction are more interesting to you. You could still be involved in the medicine, but not necessarily in the pharmacology and the physiology side. So there is biomedical engineering as well. If none of those appeal to you, think about a different career. If we look at the number of applicants in Ontario, what % of the applicants to a medical program get in? And the answer is 5%. What do the other 95 do? So I think you have to have that in mind as you're going through, as well as this is the only thing I'm interested in. Certainly there will be opportunities for some who are coming in after a graduate degree, and there are certain institutions that also take those. And as I mentioned, there are a lot of opportunities in the medical field that don't necessarily mean you have an MD. And it's becoming more and more common now for the teams to be recognized as being essential for carrying out what we need to now do in medicine.
So you don't have an MD degree yourself. You went through the research stream, and you are a doctor with a PhD. So we had a question about what do you feel are the benefits and drawbacks of your job?
Oh, lots of benefits. But I should explain that when I did my undergraduate, all my undergraduate at that time, you had to have pre-med courses that were required. I have all of the pre-med courses that were required. I made the decision not to go into the MD stream because I was more interested in doing the science side. But my degree is actually in medical sciences. And as was mentioned, I have a cross appointment in the faculty in the Department of Medicine, in cardiology as well. and with the work that I've been doing, I'm also a fellow of the American College of Cardiology, and I'm a fellow of the Canadian Cardiovascular Society as well, which is a recognition amongst those of the contributions in the area. So those for me have been much more interesting. The other part for me is that although I deal with patients, the patients that I deal with only if it's a research involvement. So I don't deal with the just standard patient care, and there are people who are really good at that. And I'm absolutely delighted that we do have those people. But that's not the part that I was the most interested in. I was the most interested in the research side and the science side, and that's what I've been doing. In my current role, I'm the vice dean, so much more of my time is spent now in developing training programs, in developing new faculty members coming in promoting things that they're doing and collaborating with other individuals. So most of my time does that, and I have a great example of that recently where I had a company who approached me, and I've worked with companies before about developing products that we can use. They approached me to see if I would be interested in working on one of theirs, and instead of that, what I said is, reality, I won't have time to do this well for you, but I have a young colleague here who does similar types of work and could make use of your type of equipment, and you could collaborate with that person and work that out, and that's now moving forward. So that's more of my reward, not personally, but globally, both for the new faculty coming on, but also to try to encourage what's going to be of help to society as a whole.
I see. So we have a quick question here by Ms. Baga's class. They just wanted a little clarification. The 4 years before getting into medical school, are you referring to an undergraduate degree?
Correct, a bachelor's degree.
Okay. Perfect. And is there anything in particular that students would need to study to go into a specific specialty in medicine? You did mention previously that you sort of suggested doing what they're interested in because that's what they will excel in. But when it comes down to getting into medical school, or perhaps after medical school specializing, does what they studied in their undergraduate degree matter a lot?
Some parts of it are across the board. You have to understand enough about basic biology of what's going on in an individual. You have to understand the basic components of anatomy. You have to understand some of the components that deal with the normal physiology that's going on. So those cross the spectrum. But if you were more interested in doing something along the lines of dealing with drugs, for example, then perhaps the pharmacology would be much more interesting and much more applicable to what you'll be doing later. And for some of those, right now, our major mechanism for dealing with patients that have high blood pressure is using drugs. And you have to understand what the effects are of the drugs, what their dynamic profile is like. Can you give it once a day, twice a day? Do you need it 4 times a day? Can you combine drugs? So in that sense, there are subsets that are more important in different streams than others. If you're interested in surgery, then the subset, of course, that's very interesting there and important would be the anatomy and the gross anatomy parts that you're dealing with.
Right.
As you get a little further along, you may be more restricted in saying, well, my areas really are hand and upper limb, or my area is thoracic. In the case of what I deal with is primarily thoracic for heart, or it may be GI, or it could be, skeletal, where you're working with bones and hips, knees, and things like that. So as you're going further along, you can become more specialized.
That makes a lot of sense. We're just going to wrap up very soon. One more quick question about that sort of preparation. Students always want to know how they can best set themselves up. Do you feel that the IB program is a benefit to students seeking admission into health sciences? That question's coming from Oakville.
The reality for my program, and it may be different elsewhere, is we do give credit for the IB, but I find that most of the students take the courses we have here instead, or on top of what they've already done, so that they can have an idea of how well they handle our university courses. And so, yes, we give credit for IB courses, but I haven't seen that they have been a particular benefit. What I usually see is that the student who took the course is a student who is more interested in doing things, and so it's more a measure of the student than it is of the course and what they got out of the course. So we have some very good students who have done the IB program and have come through our program and done very well. But what I recognize from that generally is it was the quality of the student who took the course, and certainly they got information from it, but it was really the student that was the key, not the course.
I gotcha.
Okay.
And
I'm just going to make one other comment about the, going back to my comment about, well, what do you need in high school rather than university? So the things that we would look for, and again, for the same reasons, if you're thinking about the medical side, then you need to be thinking about the chemistry, the biology, the math, the physics. And I have some students that say, well, why about physics? Why do you need physics? Well, if you want to understand a patient who has trouble when they stand up because their blood pressure isn't maintained, you have to understand fluid dynamics and what happens when you stand up because of gravity. If you need to understand why old people have problems because their blood vessels are getting too thin, and therefore they tend to have problem with consciousness at times, or they have problems with freezing fingers when they're going out in the cold, you have to understand fluid dynamics. So there are a lot of components in the high school curriculum that you don't recognize at the time has some direct applicability later.
that makes sense. So we talked already about generally studying what what you're interested in to set yourself up to be the most successful, no matter where your path takes you. You gave yourself as an example of a meandering path that now you love what you do, but that was not where you were headed back when you graduated high school. Do you have any last words before we wrap up today in terms of advice for the students or anything else you'd like them to know?
Two things. I think the one is to reiterate the fact of think of what you really enjoy. And some people say, well, I don't know what I enjoy. Usually if you sit back and just take a moment to think about it, you know which ones are the most interesting to you and where you're going. So take a moment to look at that. The other part is, as I mentioned, there are opportunities for change as you're going along. Don't think that you only have this narrow perspective of what's there. Things do change considerably. There's a lot of dynamic involved in the educational process. And the pieces that you're picking up on are the other skills. How do I teach myself things? Where do I go to look for information? How do I communicate? What are the critical thinking skills that I'm developing? And those will be appropriate whatever field you go into. So I think there's tremendous opportunities out there for all of the students that are interested in doing so. But part of it is just you have to have that, you know, what I call the fire inside to figure out where you're going.
Well, thank you very much. So we definitely enjoyed today. I'm seeing multiple thank yous come in from the classes that joined us live. And thank you from me as well for joining us, for answering questions, and for giving us a view into what that team looks like that you work with for those medical advances.
You're most welcome. Thank you very much. And I look forward to seeing some of the people who are watching this coming to Western.
Sounds good. Well, next week on PIR Live Event, we are talking about genetics and what it's like to perform experiments 2 kilometers underground at Snow Lab in Sudbury. More information on this and other live events you can find at pirweb.org. Thanks and have a great day, everybody.